Welcome to Dental XP, where we will try to give you dentistry at the cutting edge as often as we can and bring you around to real live dentistry as it's done in the clinical setting. I'm here with my partner David Garber and Marie Salama, and it's exciting for us to be able to offer you this type of continuing education and experience here at Dental XP. We're going to try to do a lot more for you in the coming months. Tonight we're going to try to show you and discuss with you what the current trends are in soft tissue grafting and the impact of soft tissue grafting on an aesthetic clinical practice. Today there are techniques, not only classic techniques like autogenous tissues, but there are techniques today, David, like alloderm and tissues that are harvested from cadavers and processed that can be used as well to facilitate the treatment of whole arches in one visit. And we're going to touch upon that as well.
I mean, you're looking at this case for years. We started off with, the free gingival graft, and that was really very limiting, not only in the amount of coverage we could get, but also in the type of coverage. Remember the old tire patch scenario that we had. I think with Bert Langer we evolved into connective tissue grafting. That was a major step forward, and then we'll take you from there into the new allograftic techniques.
I believe color has been a big thing as well. In aesthetics today, people don't only want tissue to cover the roots, they also want color. And as a restorative dentist, as well as a surgeon, you yourself know the understanding, the impact that color can have on your restorative dentistry.
Absolutely. We're not going to put an A4 crown there when we have A1s. I mean, you just can't do it the same way. Pink has to match. Even pink, when we do pink ceramics today, has to match.
So today, as you can see, the techniques in a case like this one is aimed at not only root coverage, but also for color matching of the surrounding tissues. Whether this eventually ends up with a bonding, a veneer, or nothing at all, the matching of the color of the tissue is very important because this all is below the vermilion border of the upper lip and is showcased in this patient's smile. So free gingival grafting probably would not be the way to go.
You look at this, it is really a dramatic case. And when you evaluate it, you wonder, can you do it? And if I was going to tell you anything, when you look at these cases, don't look at the amount of recession. But as we've talked about so often when we're talking about implants, the interproximal height of bone is the key here again. Look at where the level of the papillae are. Look at where the interproximal height of bone is. Evaluate the amount of curvature there is to this cemento-enamel junction, and that's basically what you're going to get in your grafting techniques.
Using P.D. Miller's classifications.
Absolutely.
I mean, if we go back and research the literature, you see P.D. Miller was one of the first ones to actually establish a sort of a horizon of what to expect from soft tissue grafting based entirely on the height of interproximal bone available. In a case like this, where the interproximal areas have not been diseased or traumatized and the bone is still adequate, the ability for us to manipulate tissue and be able to get root coverage is not so bad. It's actually quite good.
No, and all your other factors to evaluate here is your lateral spread. So you want to know how far it is from the meso to distal of this. And again, you're looking at Smuckler's early work, and if necessary, we'll flatten the root a little to diminish the curvature there that the vasculature has to reach across.
And that's certainly understated, and when we look at these cases, it's very important to recognize there's so many little issues. The flatness of the root surface, being able to diminish the convexity, as David has mentioned, but also root conditioning, as we know from Terranova and Wikestro's work at Loma Linda in the 70s, being able to apply either citric acid, EDTA, tetracycline, to condition the root surfaces prior to grafting.
Absolutely. And today we have the newer conditioners, such as Emdogain, that we can utilize.
Sure. As a bioactive modifier, we can use the EDTA agents of tetracycline and then apply a bioactive modifier such as an enamel matrix protein, such as Emdogain, which is sold by Straumann. If we take a look, it all starts with autogenous tissue, and the difference, as David mentioned earlier, free gingiva versus connective tissue. Connective tissue is certainly less traumatic to the patient. Small parallel incisions, approximately 2 millimeters below the lingual portion of the CEJ of the maxillary posterior teeth, and then a 1 millimeter parallel incision, which allows us to gain as much depth and thickness as we can attain, usually approximately 1.5 to 2 millimeters of thickness, approximately 7 millimeters of length. And in terms of the width and circumference, we have established a certain amount of tissue that we can get pretty routinely from this area.
Now, when you're looking at this, how do you go about it? When I do it, I like to make my 2 incisions just partially through And then the lower incision, the one towards the middle of the palate, I start with that one and thin it out. And then I go to the more coronal incision and take it down to osseous. Is that the way you do it?
So actually a very good idea. I mean, there are different ways to do it. I personally like to establish my parallel incisions first, and then I take the lower incision, the one towards the medial aspect of the palate, and I actually go straight down paralleling my blade. The upper incision, the one closest to the teeth, I actually come in at a perpendicular.
Right.
And I think if we can do that, the most important facet of this actually is to minimize postoperative trauma and to get good healing in this area, in this wound, is not to use a periosteal elevator, to do sharp dissection only.
Absolutely. Everyone's a little reticent to do it because we're scared of the vasculature here that you might nick, but we've really been able to control it by staying anterior to the greater palatine there, which is usually round about the mesial, or worse, the distal aspect of the second molar.
Very important to know the anatomy. We want to stay away from the height of the palate. The medial of the midline of the palate usually is where the arteries are, as well as David mentioned, the greater palatine when you're going towards the second molar. So we sort of end our incisions right around the mesial of the second molar, distal of the first molar, and you can come forward certainly without too much of a problem to the mesial aspect of the cuspid, if not the middle of the lateral incisor. So there's a certain established amount of tissue that you could get as a routine basis in this procedure. One of the nice things is not only the procurement of good, adequate autogenous tissue, but the ability for us to attain very, very easy primary closure for the patient. Here we're using 4-0 silk crisscross mattress sutures to attain primary closure, which helps expedites wound healing and makes it easier on the patient.
Real easy. I mean, you think back to the days we used to try and stuff pack in there, and you'd have this whole raw wound granulating in from the periphery. This is really a nothing procedure. The sutures loosen up within about 4 or 5 days. Many of the patients slip them out themselves.
Would you utilize a surgical stent? Do you suggest one for a case like this, like we used to use with free gingival grafts, or do you think it's not really necessary?
You know, we kind of used to do this routinely, but if I'm only doing one side of the palate, I don't. But if I'm doing two sides of the palate, I kind of do now.
I don't think it's a wrong thing to do. It's certainly a nice additional thing for comfort of the patients. They can always take it out. I think they heal better without them in. My tendency is to avoid them with connective tissue, but if I'm going to do both sides of the palate, I think it's a nice adjunct to have for them to have, just in case they get a bleeder, just in case they have a little bit more swelling or a little bit more discomfort. They can always apply it and place it in the mouth. And it's probably not a bad idea, especially with inexpensive Essex materials like from Raintree, Dentsply.
That's a great product. Great product.
And it's transparent enough for them to wear and utilize aesthetically as well. Covers all the tissue, very inexpensive to make.
And doesn't bother them. I mean, they wear it very comfortably, and you can see the primary closure that's available here. It's really very easy for them and not in any way uncomfortable.
And you can see the abundance of tissue here. Here's a probe. We've got approximately 7 to 8 millimeters of width and probably about 20 millimeters, 24 millimeters of length. What we do is we remove the epithelium, the 1 millimeter cuff, and then we apply this underneath the tissues. And what you're seeing here is it's sutured into place. And when we suture these, the biggest factor in these procedures in the anterior region, I believe, are two things. Number one is split thickness dissection, David, to allow for us to release the flap and advance it without tension and to cover the graft. And the second thing is to avoid, whenever possible, vertical incisions. What is your preference on vertical incisions in the aesthetic zone, especially in a patient with a moderate to high lip line?
I think aesthetic incision making means avoiding verticals if at all possible. If you're going to have to make them distal to the cuspid, particularly in tissue that's very thick and dense. They seem to scar and leave that vertical line. Even if we go back and laser it, it always seems. And any pigmented tissues definitely scar.
I agree.
Always do that. You're talking about your initial incision for the recipient side. So you do a split thickness down to the osseous, that's through the papilla, split. Then you go full to the mucogingival junction, and then is the time when we really split it.
That's absolutely right. I think it's always easy to split at the mucogingival junction because you have the elastin fibers in the mucosal tissues. It's much easier to do without having the complication of a perforated flap. So if you're going to do, most of your split thickness is going to occur at the mucogingival junction apical, as opposed to trying to do split thickness dissection or sharp dissection inside the attached gingiva. It's very dense tissue, very hard to do. Not that it can't be done, but certainly for people who are just at the beginning of the learning curve, probably best to avoid that.
And then it allows you to bring that tissue down, covering your graft.
probably one of the most important things, tension-free closure. We know it from guided bone regeneration, and it's the same thing here as well. And what you're looking at here is 10 weeks healing, David. We got excellent root coverage on teeth numbers 9 and 10, 100%. And we didn't hit a home run on tooth number 8. We got about 80%. We're certainly much better than where we started. Look at the thickness of the tissue on the right side. What kind of secondary procedures would you consider once you had the first procedure? What would you think about utilizing? We, in this case, decided to do secondary revision utilizing semilunar graft over tooth number 8, so we didn't have to go back and harvest additional soft tissue.
Actually, this case is quite easy because you could either do a semilunar and bring it all the way home, but if you look, the CEJ is not real evident, so you could actually take the adjacent tooth if you didn't want to up a little. Its length to width ratio is a little short, so you could take that up a little, or do your semilunar, see how much coverage you get, and then modify the others with a little crown lengthening if necessary.
Well, we did ahead here. Yeah, we went ahead and did a semilunar on tooth number 8. Approximately 3 months of healing had occurred from the initial surgery. We just moved the tissue that we had already grafted over the root surface, and you're seeing on the right screen is approximately 10 days healing. Not a whole lot of healing in that area. We also started to graft the posterior region of the mouth, the right and left side. You can see some of the sutures from that area as well. So we were grafting the entire mouth, took a series of procedures, and we're going to talk about that in a moment. And this is approximately 12 months post-op, pre-op on the left screen, and the post-op on the right screen. You can see that we've gotten pretty much 100% to 95% coverage of the roots, and an excellent post-op result, not only in terms of root coverage, but also in terms of color. I think the color has turned out quite well.
Type of color you could only get with connective tissue. There's no way you could have gotten this with a free graft.
No question. And the thickness of tissue, you can see the left side, the pre-op, and the right side, the post-op. Look at the thickness of the tissue. This is a vital graft. This is a graft that takes on a certain amount of thickness and rigidity of the ridge. And as far as the post-ops, what have you seen with these types of grafts long-term? Do they recede? Do they start to have problems, or do you find them hold up over time?
I think they actually get better with time. And Jean Ricci's shown creeping gain on over a long period of time. The other nice thing that happens is they smooth out gently. It's somewhere around about 2 years. All those little lines and all the little bubbles seem to blend in very effectively, and then you seem to get growth, let alone recession.
Sure. When would you, if you had to, and you thought about doing some minor plasting, at what period of time would you consider doing it before you've waited? Would it be 6 months, a year? When would you do a revision of the procedure just to plasti the tissues, to get the lines and bumps out of the graft?
I mean, the reality is this is going to be patient-driven. You all know it. I mean, we all live with these problems. But given my options, I'd love to wait 2 years.
I happen to agree with you, and certainly it's a case-by-case basis. I would do it as early as 6 months, and certainly if a patient was tolerant enough, I'd probably wait.
Always.
And here it is at 2 years. It's exactly what David said. No plasty had been done. And although it's not a perfect result, you can see the substantial amount of root coverage that's been attained on teeth numbers 8, 9, and 10. And also the ability for us to get excellent color matching of this area. This is what will occur over time, as you had mentioned, not allowing ourselves to jump in and start to shape the tissue. It'll happen almost on its own if you're given enough time.
And it may be that even number 9 will receive a tiny drop now related to crown form, and then they'll match perfectly within another year.
And that gets in the whole thing of aesthetic dentistry. At what point do you jump in and start to pack your cord and shape your crowns? Of course, from a smile result, you can see the substantial changes. A person with a high lip line being able now to cover the roots, and really in a more active smile when the patient's actually showcasing his gingiva. You can see that now the necessity for us to do substantial restorative procedures other than bleaching, maybe a little bit of orthodontics, Invisalign, or spring retainer to close the small diastema, really is about all that he'll need from a strictly cosmetic standpoint.
Great result. I must say, I haven't even seen this case.
It's always good to be able to look at cases like this and factor in the end what we're able to do together. On the right and left sides, again, he needed grafts done. They had to be done at different procedures. We did it over 3 different surgical procedures, all using autogenous tissue.
What do you think the cause of this was? I mean, he has quite dense tissue. It's not really a thin scallop biotype. Was this orthodontic, or was this, abfraction type lesions?
Well, what I've seen with this patient's history is predominantly orthodontically based. He had expansion done, he had non-extraction orthodontics, and probably some of it had to do with a small maxilla and expansion beyond the alveolus with a patient that otherwise may have had some issues with oral hygiene. So I think controlled occlusal trauma may have had something to do that during orthodontics. You can look at the amount of grafting. People always ask me, how many teeth can you graft? And with autogenous tissue. And here's a graft that takes you all the way from the molar to the cuspid. And this is not so far-fetched now practice. You've seen us do this quite often.
I mean, this is from the right-hand side now.
Right
Quite often
side.
we've actually been back and harvested from the same side again, which is amazing.
And as little as 3 or 4 months, I think you can go back to the same side, and the tissue grows and fills right in, giving you adequate tissue to do further grafting. Again, envelope flaps, we don't leave the papilla, we don't do verticals unless we need to, and then we advance it over the existing autogenous tissue, trying to get primary closure, vertical releasing. We suture with 5-0 interrupted vicryl mattress sutures. You're seeing 10 days on the left side. You can see the reddish color of the tissue showing initial vascularity, anastomoses, capillarization, and blood infusion of the graft. And on the right side, approximately 3 months. And you can see now the right side, the pre-op, and then the post-op on the right side. Very, very substantial. Root coverage, approximately 90 to 100% root coverage on all these teeth. On the left side, a similar approach. Again, autogenous tissue taken from the left side. 4 teeth have been grafted, coronally positioned flaps, and then 10 days, 3 months, and then approximately 1 year. Complete coverage of the roots, anywhere from 90 to 100%. Would you say that this form of root coverage has been something that is unusual or pretty commonplace in our practice?
I think this is routine in our practice. I think connective tissue graft is one of the basic elements in our day-to-day practice, not only for this, but for implants, for ridge augmentation. It's something that we've learned to do on an incredibly repetitive basis. This is a great result again.
We owe Dr. Langer, Dr. Kalagna certainly all the respect for being able to bring this to the dental field in the early 80s. And you can see the left and right side pre-op, and then the left and right side post-op at 1 year. Substantial root coverage attained all the way from molar to molar, including the anterior region.
You look like you're coronal to CJ, even on the cusp, but great.
And what's interesting actually is when you look at a case like this, what was the downside? 3 visits, 3 surgical appointments done over a 12-month time frame. You have to have a patient with an unusual amount of motivation, determination to get this done. And still, this is the gold standard as far as I'm concerned, but some patients aren't willing to go through numerous procedures like this. This is one case in point. This is a study that we started in 2005 where we did split mouth studies testing the utilization of autogenous tissue, the classic technique we've just shown, versus the utilization of acellular dermal matrix tissue. This is Alloderm made by LifeCell and distributed and sold by BioHorizons. And we're going to split this case up. So a similar case to the one you just saw, full mouth grafting, except the anterior region in the aesthetic zone, we're going to use autogenous tissue. And then the posterior right and left, we're going to use Alloderm tissue. And we're going to do this all in one visit.
I mean, that's great. I mean, that's a really dramatic change for us. You think you'll get the same kind of results?
I think you'll get a very, very good result. I think what I've seen is excellent results, but I do not believe that we can say that they're equivalent results to autogenous tissue for many reasons. One thing is autogenous tissue is a vital tissue and heals vitally. It immediately gets taken up by vascularity and sustains its vitality. Whereas Alloderm really needs to be taken up and replaced by the patient's own body. It's not vital tissue. It's not vital wound healing. If you see this case, the first thing we do is we're going to prepare the root surfaces. As I said earlier, either EDTA, this is Pref Gel by Emdogain, and this is sold by Straumann. And this material is a neutral pH, can apply to the roots to open up the dental tubules, or you can use tetracycline paste, either one of these for a period of 3 minutes. We raise a envelope flap, sulcal incision of the entire arch from molar to molar. And then we procured some connective tissue from one side of the palate for the anterior region, the very aesthetic area, and the back of the mouth, the right and left sides, we're going to use Alloderm. And we go ahead and we make sure that we're placing the graft. We have enough graft for the anterior region, the autogenous tissue. and we suture the autogenous tissue into place. And one of the things that's interesting about autogenous tissue is you can leave some of the autogenous tissue exposed. I think that's probably the biggest factor of success or failure with alloderm, is that I think it works much better when you can completely cover alloderm, as opposed to autogenous tissue where if you leave some of it exposed, because it's a vital wound healing, it's still fine. What have you found?
I mean, I like to bury alloderm completely. I'm just uncomfortable when I leave it exposed. I don't like the way it looks. But when we've buried it, we definitely get great results. I don't think the result is an equivalent. It's a different result. But it may actually be as good functionally, because you're getting this barrier deep as opposed to the superficial barrier. And you feel it and you actually probe it. There's a dense tissue underneath. It doesn't move, and it may work just as effectively.
One of the limiting factors, I believe, if there is such a thing with alloderm, is that I do like to cover it only when there's at least a small band of remaining keratinized attached gingiva. So if we're going to use this, at least in our hands, and certainly Pat Allen has shown some beautiful stuff with almost any situation, is for David and I, we really like to use it when there's still a remaining band of keratinized gingiva, because in the end, that keratinized band of gingiva allows for the cells to be able to come in from that keratinized gingiva and add in the replacement of the alloderm tissue. And again, utilizing these products, you're seeing it on the right screen, Emdogain gel, which is an enamel matrix protein, a bioactive modifier, which speeds up the wound healing and the attachments of the fibroblasts from the outer flap to the dentinal tubules, and alloderm, which is an acellular dermal matrix, which is procured and sterilized, treated cadaver tissue made by LifeCell. We place this over the roots in the same way that we do autogenous tissue. One of the important factors is if you're going to ever use vertical incisions, what's been shown by the work of Dr. Nevaez in Brazil is that these vertical incisions should always be at least 1.5 teeth beyond the border of the alloderm tissue for vascularity's sake. So in this case, again, envelope incisions allow us to go ahead without a problem. We do the right and left side, utilizing Emdogain onto the root surfaces first, and then the layering of the alloderm over the top, and then doing coronally positioned flaps here. Now in this case, what's interesting is we did this exactly as we did the autogenous tissue as part of our study. We left a small part of the alloderm exposed, much in the same way that we did the autogenous tissue anteriorly. What's great about this, okay, when we think about the shortcomings of alloderm, but how about the advantages and benefits? This patient came in, and in an hour and a half, she was treated for the entire maxillary arch in one sitting.
No way we could have pulled that off any other way. I mean, we could take two sides of the arch. We've even taken a large depth and split it, but that would have been a little too much.
This is an exciting protocol. It allows us to do a tremendous amount of grafting in one visit. As a matter of fact, I don't think it's exactly impossible to have done even in an entire lower arch, if so be it, with the same protocol at one visit. So it's exciting. Take a look at the wound healing at 10 days, how different it is. In the anterior region, where we use autogenous tissue, the tissue at 10 days is still pink. There's still vital wound healing. The fibroblasts are still alive. The initial infusion of blood from the surrounding tissues and then initial capillarization at 24 hours, as we know from wound healing studies, keeps that tissue alive. In the posterior region, beautiful healing. But if you look at the alloderm that's been remained exposed, it's white. And that's part of what I would say, if there is a shortcoming, the shortcoming is that you have a non-vital healing. You have no fibroblasts in this tissue. It's acellular. And therefore, it's dead tissue that has to have time to be remodeled and replaced with the surrounding tissues.
I think if we weren't doing in the study, if you just brought the tissue down, it would have been easier if you brought it coronal in the mid-facial aspect.
No doubt. I would have to agree with you. Looking back at this, obviously, initially in part of our study, we were doing this to try to compare it directly with autogenous tissue. The technique now for us would have been to completely cover the alloderm, and what we would have probably seen is a very, very equivalent result to what we saw with the autogenous tissue anteriorly.
In fact, it's almost better sometimes early on because it doesn't get as red.
That's true.
The tissue actually looks nice early on. But look at the results.
Similar thicknesses as well. But look at the result at 10 weeks. It's very hard to determine which part of this patient was allograftic tissue and which was alloderm. we may have 100% root coverage in the anterior, maybe 90% in the posterior region. The color match is equal, no scarring from vertical incisions. But more importantly, this patient was treated in one visit in 45 minutes.
That's clinical reality. I mean, that's day-to-day practice.
This is what she came in with as part of our study. We'll be publishing on this in late 2006. We submitted 10 cases. It's a case report, a split-mouth result. Take a look at how she came in. What's more important is what was done in just one visit. On the right screen, the post-op at 1 year, the middle screen, 1 year, and the left side at 1 year. Tremendous result. This patient wants to go through orthodontics, but you could have never continued with orthodontics to close her spaces and align her teeth without first going ahead with grafting. Would you use alloderm? Would you feel comfortable doing that prior to aesthetic procedures, restorative procedures, or orthodontic procedures?
Oh, absolutely, I would. I mean, we've even started to use it sometimes in ridge augmentations. So I see no reason not to use it. You know, we worked in slowly with a certain amount of trepidation. It was a new product, but we've had such nice success that we're using it more and more.
I think it's very exciting technology. I think it's important to learn the techniques. I think surgical techniques are very important, making sure you don't make small vertical incisions, making sure that you can completely cover the tissue, making sure the patient's on antibiotics. There's been some beautiful research done by Lee Silverstein here in the Atlanta area. It actually talks about bathing the material in antibiotic before he places it. We know the work from Pat Allen talking about the utilization of PRP, platelet-rich plasma, and coating and bathing the alloderm in PRP. All of these things may, in fact, allow for even a more predictable wound healing with this material.
And I think the way we've changed incisions, I mean, I saw you using the new stoma kit recently and tunneling underneath the papilla like Pat had shown some time back. Makes it easier to suture, bring that tissue a little more coronally
and
easily.
Stabilize the graft.
I mean, it's much easier, I thought.
As a matter of fact, I would have to give Dr. Allen, again, Pat did a great job showing us some of these new techniques, utilizing an alternative tunneling technique where he doesn't raise each opposite papilla. He goes ahead and tunnels underneath it, which stabilizes the graft in place, utilizes a lot more PRP, and I think that would allow us to get maybe even better healing. So the techniques are so important, and we've started to use some of those techniques and seeing some very good results. And here you see the patient approximately 10 months. You should see the healing in a patient with a high lip line, great color, great tissue color. We have substantial root coverage, not only in the anterior region with the autogenous tissue, but also posteriorly with the alloderm tissue. And this is something that's become quite standard. So it's an exciting time to be doing these procedures. We're very excited to be able to offer you this small lecture on connective tissue grafting and soft tissue techniques in the procedures, what we're doing here in our office. And hopefully we'll be able to continue to advance these techniques and share this with you more in the future, utilizing this format. Dental XP has really been able to allow David and I to do this here in our office. Very comfortable for us. This is after hours, doing the procedures and bringing it to you exactly the way we do it and exactly the way we think. We'd like to certainly have you visit with us more often and give us some of your feedback. Let us know what we can do better or worse. And also for us, it's very important for you to understand that we end our days with something that we always share together, and that's a bottle of scotch and a couple of glasses. So to all you out there in Dental XP land, please share with us a drink sometime. Come visit us, take one of our in-house courses, or just come and visit us on Dental XP. We're going to be doing live sessions and treatment planning sessions in the lounge here as a real-time interaction between us and our team here, the Team Atlanta, and your team out there in Dental XP land. And thank you for attending the course tonight, and we hope to see you again soon.
Cheers.
Cheers. David?